From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Welcome to the JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today we're thrilled to be discussing a new paper just out in JAMA Psychiatry about slowing cognitive decline in major depressive disorder and mild cognitive impairment, a randomized controlled trial. We're about to be joined by Dr. Tarek K. Rajji, MD, and Dr. Benoit Mulsant, MD, both at the Department of Psychiatry and Toronto Dementia Research Alliance, University of Toronto in Toronto, Ontario, Canada. At the time of the airing of this podcast, Dr. Rajji is now at an appointment at University of Texas Southwestern in Dallas, Texas, United States. Cognition and cognitive decline is associated with many mental health and brain conditions. Well recognized in mild cognitive impairment, a condition that increases the risk of developing Alzheimer's disease, cognitive decline is also a core symptom in major depression as well. And mild cognitive impairment and major depressive disorder are often co-occurring. Fortunately, we have effective treatments for cognitive symptoms, including transcranial direct current stimulation and cognitive remediation, among others. But how well do these two treatments work, and are their effects the same or different in depression as well as mild cognitive impairment? To answer these questions, we'll explore the results of a brand new study just out in JAMA Psychiatry. Thank you for joining us, Dr. Rajji and Dr. Mulsant. Let's talk about cognitive decline in depression and mild cognitive impairment. What is the actual decline and why it may be related between these two conditions?
So thank you, Dr. Torous, for inviting us to talk about our study. As you mentioned, it's well known that some people who present with MCI, mild cognitive impairment, are at high risk for developing dementia. It's less well known that people who have had or have a major depressive disorder are also at high risk for developing dementia, and that before they develop outward sign and symptom of dementia, they are presenting with cognitive impairment or cognitive decline, even when their major depressive disorder is in full remission.
And we do have treatments for cognitive impairment. Can we quickly review cognitive remediation and transcranial direct current stimulation and how those two may help in this case?
Cognitive remediation is a group intervention that consists of training participants in a classroom on computerized exercises and talking about what different strategies they can be used to resolve those computerized exercises. But in addition to that, there is a component where the therapists in the classroom or the interventions in the classrooms are also discussing with the participants how to transfer the strategies they are learning for the computerized exercises, how to transfer them, apply them to their real world problem to help them cope with the cognitive difficulties they have. And that's a key component that separates the sham. That component doesn't exist in the sham component of cognitive remediation. Transcranial direct current stimulation, or TDCS, is a form of neuromodulation that delivers 2 milliamp direct current to different regions of the brain. In our study, we focus on the frontal region of the brain, also lateral prefrontal cortex, or bilaterally. And underneath the stimulation, it changes the excitability of the brain. In our study, what we're aimed for is to increase excitability of the frontal region of the brain so that it responds better to the cognitive remediation intervention by optimizing what we refer to as cognitive compensatory mechanisms.
You've told us about these two interventions. We have cognitive remediation, we have transcranial direct current stimulation. Before you did your study, what was the evidence on, say, combining both of these, right? We have two treatments, maybe two treatments together are going to be more effective. What did we know about this before your study?
There is some evidence that cognitive remediation can be useful to improve cognition in older adults. And there is some evidence that TDCS can also be useful, particularly in older adults who have a major depressive disorder. But before this study, there was really no evidence showing that their combination could be more useful than each individually. And the effect of each intervention alone was modest. So the study was predicated on the hypothesis that by combining two treatments with modest efficacy, we could have a more robust intervention.
And TCDS is also transcranial direct current stimulation, one of the two big interventions we're talking about with the authors. Following up on that question, that we think two could be more robust than one, but we don't have great evidence before the study about combining both of them. This paper does explore the combined intervention. Can you tell us more details about why you think that combination was going to be effective, especially in this use case for people with mild cognitive impairment and depression?
So as I mentioned earlier, the idea is that it facilitates neuroplasticity in the brain. So it renders the brain networks being stimulated by TDCS more responsive to another intervention like cognitive remediation. The hope is that to get a synergistic effect, so more augmented effect when the two are combined. So if the effect of cognitive remediation and so on is modest by quote unquote priming it with TDCS, we can get more augmented effect. That was the scientific rationale for why to combine them, and combining them to target the networks that are responsible for cognitive compensatory mechanisms and why those networks, so that we slow down the cognitive decline and help individuals with these two conditions, MCI and major depressive disorder, both high-risk conditions, helping them cope with the cognitive difficulties and therefore slow the cognitive decline through compensation.
That's a nice explanation how one is helping prime and make the treatment more effective of the other. In doing this, what was you and the team's main hypothesis and the main outcomes that you were assessing to judge that hypothesis?
The main primary hypothesis was that the combination of active CR or cognitive remediation plus active TDCS would slow down cognitive decline using global cognition as the primary outcome measure, compared to sham cognitive remediation combined with sham TDCS. And that's over the 7 year of the study, or the median follow-up of 4 years. We had two other hypotheses. One is that categorically we would see lower progression from normal cognition to MCI state or MCI to dementia, and among the participants who would receive the active intervention versus the sham. We had also another hypothesis, a third hypothesis, that in the short term, because there was an acute phase of the study where participants were receiving the intervention 5 days a week for 8 weeks. So there was an acute hypothesis which stated that after the 8-week intervention, we would see better cognition, better improvement among those receiving the active versus the sham intervention.
Tell us about who joined the study and who are the people you recruited into it. What does the sample look like?
So we recruited and randomized 375 older adults, and they were recruited through various mechanisms. The study was conducted in 5 academic health science centers in Toronto with large department of psychiatry. And you had geriatric psychiatrists to refer their own patient, typically patient with depression or MCI or both. And when somebody presented with an acute depressive episode, they were treated to the point of remission, at which point they became eligible for the study. In addition, we had ads in the Toronto metropolitan area to recruit a volunteer with an history of a major depressive disorder who had been diagnosed with MCI and were interested in participating in the study that could potentially prevent the onset of a dementia by slowing down cognitive decline.
That makes sense. And for those of you listening to, MCI is mild cognitive impairment and related to dementia in some ways. Any other details that you think listeners need to know about the study before we talk about the main results, about how the study was run?
This was a randomized, controlled, and it was double blind. So the randomization was the two arms, active versus sham. The sham was the control. The masking was for participants. So participants did not know whether they were getting the active or the sham. The assessors of the primary outcome and the PIs and the investigators and most of the team were also masked. The only individuals who were not masked, were not blind, quote unquote, were the interventionists in the classroom. These were the ones who needed to decide whether to do the transfer discussion about the strategy or not. Participants came in first, so joined in class setting. So they joined in groups of 4 to 8 people at one setting in one classroom. First, they were receiving the intervention 5 days a week for 8 weeks. Each day, they would get about 2 hours of cognitive remediation. And during the first half hour, they were getting TDCS, so the electrical stimulation, while doing the cognitive training, and specifically while doing an executive function cognitive training. And after those 8 weeks, they would come back every 6 months to do a booster week, 5 days a week, again, receiving cognitive training plus TDCS until the end of the study, which some participant was up to 7 years. The median follow-up was 4 years. In between those booster sessions, participants were asked to do the cognitive training at home 20 minutes a day, at least once or twice a day. And then the assessments for the primary outcomes were done at baseline, so at the beginning, before they started the 8 weeks. Then at the end of the 8 weeks, about 2 months from the beginning, and then yearly from baseline, they would get a full neuropsychological battery that would measure their cognitive performance, including generating the primary outcome measure, which is global cognition.
That's a very useful overview of the study, and again, very impressive, the duration of this study. A lot of studies are oftentimes much briefer. So I'm just so curious to ask you, what were the main results around global cognition?
Fortunately for us, the investigator, and for patients and people in the field, the primary outcome was positive. As you mentioned, participants were followed for up to 6 years, and every year, starting at year 1, 2, 3, 4, 5, and 6, the participant who had been randomized to the active intervention had a lower cognitive decline than the participant who had been randomized to the sham control intervention. So if you look at the main figure in the paper, you see that after an initial boost in cognition at month 2 in both the intervention group, the active and the sham group, global cognition returned to baseline after 6 years in the active group and only 3 years in the sham one. And that was true in the whole sample of other adults with MCI or with remitted major depression, with or without MCI. But the effect was stronger in those with remitted major depression. So if I was talking to somebody who said, what kind of benefit can I expect from this intervention? I will tell them, you get a delay of about 3 years of your cognitive decline.
Very impressive result. And definitely it sounds like the synergy of both of them, these interventions together, was very useful. I will say there's so many exciting figures and tables in the paper. I encourage everyone listening to also look at it because there's only so much we can cover. Are there any other specific results around cognitive domains we can talk about?
We had planned all these secondary analysis, so including looking at the changes within each of the 6 cognitive domains that form the global cognition. So executive function, processing speed, verbal memory, visual memory, and so on. There are 2 key findings that we found. One is in the short term, the acute phase, we did see that those who received the active treatment improved more on executive function than those who received the sham. And in a way, this was consistent with our model, with how we designed the study, because again, we were aiming, whether through cognitive training, we focus a lot on executive function training, and through the TDCS, we focus on the prefrontal related networks, which involve an executive function. The second finding, is that over time, there was a very robust finding on verbal memory. What we found is that if you look at the figure, not only there is a slowing down of decline in verbal memory over time, over the median follow of 4 years, but there may be even improvement in verbal memory over time. There's a lot of secondary analysis we could look at to try to understand whether, for example, this initial boost in executive function led later on to this improvement in verbal memory over time, which led to an overall slowing of decline in global cognition.
certainly a very exciting result, because any of these cognitive domains that are improving or declining less rapidly, that means that people can do more. You're giving people more functional outcomes and opportunities. Are there any other core results that you would want listeners to be aware of?
There are two key also pre-planned analyses that we want to highlight. One is there a difference in response between those who have MCI or mild cognitive impairment without depression or remitted major depressive disorder versus those who have the remitted MDD? And just a reminder that participants to enter the study, they had to be in remission from major depression, or not acutely depressed. These individuals are still at a high risk of developing dementia. And indeed, we did find a big difference. So most of our response for the whole sample was driven to a large extent by those who are in the depression group, the MDD group, and not the MCI group. And this finding is consistent actually with few studies that were published during the PACT-MD trial. They started afterwards to an extent and then finished earlier because they are all acute studies. As you mentioned earlier, Torous, they were shorter trials. The main ones, they did find that there is no really significant robust effect when combining cognitive training with TDCS for MCI only. So our long-term results are consistent with these results in the MCI group. But also what they show is that there seemed to be a specific and robust effect in those who have RMDD, irrespective of whether they have MCI or not, because our RMDD group could have MCI also with them or not.
And MDD being major depressive disorder, right?
Major depressive disorder. The second key finding that we looked at is whether being ApoE4 carrier matter in terms of response. And what we did find for the whole sample is that those who are non-carriers, who don't have one or two alleles of ApoE4, seem to be the ones who actually benefited more from this intervention versus those who had any carrier, which could have some implications in terms of the new treatment that are coming out for people who have disease-modifying therapies for Alzheimer's disease, where you need to have some Alzheimer's pathology, that maybe this could be an intervention that's more suitable for those who may not have that much of pathology. This is all speculation at this point. There's a lot of analysis need to be done to really look into those findings, but these are the two key additional results in the study.
On speculation, again, you have these impressive results. What does this mean for prevention in this space? We know that in this kind of world of Alzheimer's or dementia-related diseases, we want to move towards prevention. We want to stop prevention of depression reoccurring. How do you think these results inform prevention?
As mentioned by Dr. Rajji, the people who benefited the most from the intervention are those with an history of major depressive disorder. What's interesting is currently there is no treatment that evidence-based to prevent dementia and cognitive decline in those people. We are starting to have treatment for people who have Alzheimer's pathology, some specific new generation of medication, but there is no reason to believe that those treatments would be helpful in people who have an history of major depressive disorder and do not have Alzheimer's pathology. So, as you say, it's speculative, it's too early. We need replication and confirmation of our finding. But if we are successful, what we are proposing is we may have come up with a treatment that could delay cognitive decline and onset of dementia by up to 3 years in people who have an history of depression and present with cognitive impairment.
Clinicians listening to this today, seeing patients, what do you want them to know and act on and do a little bit differently after hearing and reading about your results?
Unfortunately, as I mentioned, we probably need a large replication trial before clinicians can recommend this treatment to their patient. Cognitive remediation is widely available. Some centers propose TDCS. I'm not aware of any places where people are offering the combination. And outside of research study, at this point, I don't think practicing physicians should necessarily recommend their treatment. But it's my hope that we may have another podcast 5 or 6 years from now, and we can say the answer to your question is those treatments should be implemented widely for that at-risk population.
It's exciting, right, that both of the treatments you're talking about, they are available today. As you said, just a combination is not often given. So perhaps we've covered my question, but what then are those next steps that we can get to the point where maybe this is going to be something that is offered commonly?
Yes, I think as Dr. Mulsant alluded to, the next step is to confirm the efficacy of this combination in a sample that's only consisting of people with history of major depressive disorder, with or without NCI. That's irrespective of that. That would be large enough, powered enough to confirm that efficacy, and also to allow us to examine the mechanisms, what lead to that efficacy from a cognitive perspective. In addition to that, Impact MD, we had collected a lot of biological data, whether it's imaging, MRI, PET scans, peripheral biomarkers, neurophysiology measures. So we have a long list of planned analyses to examine what are the relation between some of these biological measures and the response. Are there subgroup of individuals that respond better versus other based on these biological markers? And for some markers, if they change, do they lead to change in the response to this trial?
What Dr. Rajji is talking about is one of the holy grail of psychiatry. It's really based on all those other data that we have not talked about today. Can we personalize treatment and identify even subgroup of people who are more likely to benefit from the treatment?
Yeah, because everything we talked about today was amazing population level results, but as you're saying, there's going to be some personalized results that we may have coming next. So it sounds like you both will be busy for some time doing this work, and I think we're grateful you're doing it. That's all the time we have. I'm John Torous, and I've been speaking with Dr. Rajji and Dr. Mulsant about slowing cognitive decline in major depressive disorder and mild cognitive impairment, a randomized controlled trial. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thank you for listening.